Hopefully by this time in your life and in your academics, and at least in this discussion we've been having about the cardiovascular system, you've realized the importance of a properly functioning heart. So our cardiovascular fitness is very important to the functioning of the heart. Thankfully, it can be increased at any age with regular exercises. Aerobic exercises are really good for improving the health of the cardiovascular system. So aerobic exercises are those that work large body muscles for at least 20 minutes and elevate cardiac output, accelerating metabolic rate. 3 to 5 times a week of 20 minutes of aerobic exercise are usually recommended if you're trying to improve the health of your cardiovascular system. Some of the more common and easy to do aerobic activities include brisk walking, running. Cross-country skiing is recommended, but those of us here in the South don't do a lot of cross-country snow skiing, right? However, we can find a watering hole or an ocean or a river and go for a good swim. And all of these, of course, are going to be considered aerobic activities that are going to increase the oxygen demand of our muscles and increase our cardiac output. Also help to ensure proper functioning of the respiratory system. So after several weeks, our maximal cardiac output is going to increase and our body is going to be much more efficient at using the oxygen that is taken out to body cells. However, there are times when the heart fails. A person has decreasing ability to exercise or even move around. There are surgical techniques and medical devices that can aid a failing heart, so we'll examine a couple of those. A cardiac or heart transplant is when the heart of a severely damaged patient or a severely damaged heart is replaced with a normal heart from a brain-dead or recently deceased donor. Cardiac transplants can be performed on patients with end-stage heart failure or coronary artery disease. Once a suitable heart is found, the chest cavity is exposed through a mid-sternal cut. The patient is placed on a heart-lung bypass machine, and that oxygenates and circulates the blood. The pericardium is cut to expose the heart. The diseased heart is removed. Usually, though, they leave a little bit of the posterior wall of the left atrium. And then the donor heart is trimmed and sutured into place so that the remaining part of the left atrium and the great vessels are then connected to the donor heart. The new heart is started as blood flows through it, and sometimes it takes an electrical shock to restore a normal rhythm. The patient is eventually weaned from the heart-lung bypass machine and the chest is closed. However, these patients have to remain on immunosuppressive drugs for their lifetime to prevent rejection of that heart. Now, I've got a couple of really cool things I want to talk to you about on the next couple of slides. So when we're talking about the intraaortic balloon pump and the ventricular assist device, this is not something I'll test you on, but it's really cool and there's some cool information. So I'm not going to test you on this, but we'll pick back up with test information in a minute. But most of you are going into a health-related profession, so I don't know. I just think it's cool and I wanted to share it with you. Usually a donor heart is perfused with cold solution and then preserved in sterile ice. This can keep the heart viable for about 4 to 5 hours. In May of 2007, surgeons in the U.S. performed the first beating heart transplant. So the donor heart was maintained at low body temperature and hooked up to an organ care system that kept the heart beating with warm oxygenated blood flowing through it. And this was able to preserve that heart for several hours. So this method greatly prolongs the time between the removal of the heart from the donor and being able to get that heart transplanted into a recipient. It also decreases the injury to the heart when the heart's deprived from blood, which can lead to tissue rejection. This also, if the donor heart is coming from somewhere that's farther away, or if it's going to take longer for the surgeon to get in to perform the transplant. I mean, most hospitals don't have a lot of transplant surgeons, right? So this new methodology can preserve that heart so it will be viable when the transplant can take place. Heart transplants are pretty common today and usually produce pretty good results. However, the availability of the donor hearts is very limited. A lot of people are resistant to being organ donors because they're afraid that measures won't be taken in a hospital to preserve their life if they are a donor. Rest assured that is not the case. The first priority of medical professionals is to preserve your life when you are in danger, and they will do everything that is possible. And only if there is no other option and you are an organ donor will they harvest those options or harvest those organs and, of course, give someone else the life that you may no longer be able to have. All right, so let's talk a little bit more about some of these really cool things. Again, this is not information for your test, but an intraaortic balloon pump is when a balloon is mounted on a catheter that's inserted into an artery in the groin, and then it's threaded through the femoral artery up through the thoracic aorta, and then a pump inflates the balloon with gas at the beginning of ventricular diastole. So as the balloon inflates, it pushes both blood backwards toward the heart, and of course that improves coronary blood flow, and forward toward the peripheral tissues. The balloon is then deflated rapidly before the next ventricular systole, drawing blood out of the ventricle and making it easier for the ventricle to eject blood. Because the balloon is inflated between heartbeats, it's called intraaortic balloon counterpulsation. Wow, I know you're glad I'm not putting that on the test, right? The second thing I wanted to show you, again, because I thought it was pretty cool, is a ventricular assist device, which is a mechanical pump that can help weaken ventricles be able to pump blood throughout the heart so the heart doesn't have to work as hard. A ventricular assist device may be used to help a patient survive until a heart transplant can be performed. When that's the case, it's called a bridge to transplant, or it can provide an alternative to heart transplantation, and then we call it destination therapy because it is the function, or it's going to assist with that function rather than just being a bridge to get us through to transplant. We classify these devices according to the ventricle that requires support. So a left VAD, the most common, helps the left ventricle pump blood into the aorta. A right ventricular device is going to pump ventricular blood into the pulmonary trunk. A biventricular device helps both ventricles perform. So the type of VAD used is going to depend on the specific needs of that patient and how to best help their heart to do its job. All right, we're moving back into test material here. Now, I won't test you as deep as I'm going to cover this, but the information here is very applicable as we continue to talk about blood pressure and how some of these coronary artery diseases will affect blood pressure. So when I'm talking about certain risk factors and I'm talking about some of the some of the basic statistics, I guess we could say, of coronary artery disease, I certainly don't want you to spend a lot of time stressing on that. I'm probably never going to test you on statistics, but the importance of what's going on in the human body, I will certainly expect you to know. Coronary artery disease affects about 7 million people annually, and it's responsible for about 750,000 deaths in the United States alone each year. So it's the leading cause of death for both men and women. CAD, coronary artery disease, results from the effects of an accumulation of atherosclerosis plaques that we'll talk about in a few minutes. And those plaques accumulate in coronary arteries. That results in a reduced amount of blood flow to the myocardium. Some individuals have no signs or symptoms. Other people may experience angina pectoris or chest pain, and others suffer heart attacks. So there are certain risk factors for CAD. Those risk factors include smoking, high blood pressure, diabetes, high cholesterol, type A personalities, ooh, I know somebody like that, obesity, sedentary or not very active lifestyle, and a family history of coronary artery disease. Most of these can be modified, though, by changing your diet or your habit, or can be controlled by taking medications. But some risk factors are what we call unmodifiable unmodifiable or out of our control. These include your genetic predisposition for CAD, such as your family having a history of CAD at an early age. You can't control your age or your gender. For example, adult males are more likely than adult females to develop CAD. But after the age of about 70, the odds are pretty much equal. However, smoking is undoubtedly the #1 risk factor for CAD-associated diseases, and that roughly doubles your risk of dying from cardiovascular disease. So what are we talking about with these atherosclerotic plaques? So a thickening of the walls of the arteries and a loss of the elasticity are the main characteristics of diseases that we call arteriosclerosis. One form of arteriosclerosis is atherosclerosis, and this is a progressive disease that's characterized by the formation of atherosclerotic plaques in the walls of large and medium-sized arteries. So for these plaques to develop, we have to talk a little bit about some of the lipoproteins in our body and in our diets. So cholesterol is a lipoprotein that must be transported in the blood because it can't move around well, it doesn't dissolve well in water, it's not water soluble, so we have to combine it with other lipoproteins. Those two major lipoproteins that combine with cholesterol are called low-density lipoproteins, or LDLs, and high-density lipoproteins, HDLs. LDLs promote atherosclerosis. Ooh, that word didn't come out well. Atherosclerosis. So the cholesterol that's attached to LDLs is commonly called bad cholesterol. HDLs, the high-density lipoproteins, remove excess cholesterol from the body, transport it to the liver so we can eliminate it. Because they do decrease the cholesterol in the body, the HDL-bound cholesterol is typically referred to as good cholesterol. So basically, you want your LDLs to be low because they cause you to keep all the cholesterol. Your LDLs cause you to get rid of bad cholesterol, so you want your LDLs low and your HDLs high. Okay, so everything so far was good stuff other than the statistics and the numbers, right? So yes, you need to know what atherosclerosis is, HDLs and LDLs, what the risk factors are. Not so much that we have 7 million people affected each year, right? But what I do want to talk about now is something that is relevant but not test material, and that's the treatment of coronary artery diseases. So these include drugs such as antihypertensives, nitroglycerin, which is a vasodilator, causes the vessels to be bigger so more blood can flow through, beta blockers, cholesterol lowering drugs, and clot dissolving agents. But there are also certain surgical and non-surgical procedures to increase blood supply to the heart as well. Coronary artery bypass grafting is a surgical procedure where a blood vessel from another part of the body, a lot of times this will be your great saphenous vein that is like a spare part in your leg. So a piece of that will be harvested and attached or grafted to a coronary artery to bypass an area where there's blockage. A piece of the grafted vessel is then sutured between the aorta and the unblocked portion of the coronary vessels so that blood flow to those tissues beyond the blockage can be restored. This is sometimes done in multiple vessels when you have several blockages and those vessels have to be grafted to restore blood flow. And here you see a bypass. Okay, so we've got the aorta here and the right coronary artery. So if we look at the enlarged picture, you can see that here in the right coronary artery was an obstruction. So the vessel that was grafted bypasses the blocked part of the right coronary artery by attaching to the aorta and then just beyond that obstruction, therefore restoring blood flow downstream, I guess you could say, of that blockage. A second type that we want to, of non-surgical procedure, we want to look at is the coronary angioplasty. So this is when a balloon catheter is inserted into an artery, usually of an arm or a leg, and then gently guided into a coronary artery. Dye is released, and angiograms, or sort of like video x-rays of the blood vessels, can then be used to locate the plaques. Next, a catheter is used to advance to the point of the obstruction, and a balloon-like device is then inflated to squash the plaque against the blood vessel, and by squishing it out and making it smaller, making it thinner, then more blood flow is restored through that vessel. Because somewhere between 30 and 50% of the coronary angioplasty opened arteries will fail due to restenosis or re-narrowing within 6 months or so after a procedure is done, a stent may be inserted. A stent is a metal, very fine wire tube that's permanently placed in an artery to keep that artery open and permit blood flow to circulate. So here you can see an image of a stent within an artery, and here is an actual angiogram showing a stent that has been placed in the circumflex artery. Okay, so remember, no testing on the bypass grafting or the angioplasty or the stent, but we're back now again into testing information. So congestive heart failure is when there's a loss of pumping efficiency by the heart. Causes of congestive heart failure include coronary artery disease, congenital defects, something you're born with, long-term hypertension, which increases after load, myocardial infarctions, where you've got dead heart tissue, and valve disorders. So the pump becomes less effective and more blood remains in the ventricles at the end of each cycle, and gradually the end diastolic volume preload increases. At the start of congestive heart failure, the increased preload may promote increased force of contraction. Remember, Frank Starling law of the heart, right? But as preload continues to increase, the heart is eventually going to be overstretched and contracts less forcefully. So very much like overstretched elastic in your underwear stops being able to stretch. So same thing happens if that prolonged stretching occurs with the heart muscle. So the result of that is a potentially lethal positive feedback loop. The less effective pumping leads to even lower pumping capacity. Very often you find that one side of the heart starts to fail before the other. So if the left ventricle fails first, it can't pump out all the blood it receives. As a result of that, blood backs up in the lungs and causes pulmonary edema. Fluid accumulates in the lungs, and that can lead to suffocation if left untreated. If the right ventricle fails first, blood backs up in the systemic circulation, and over time the kidneys can increase. The kidneys will cause an increase in blood volume. If this is the case, the resulting peripheral edema is usually the most noticeable in the ankles and the feet. Congenital heart defects are the most common type of birth defect. Some of these are not serious and may go the entire person's lifespan without knowing they have these defects. Others are more serious and require surgery. One or two of the more common types that develop allow for the mixing of oxygen-poor blood with oxygenated pulmonary blood. The first one we'll look at is a septal defect, and that's when there's an opening in the septum that separates the interior of the heart into right and left sides. An atrial septal defect, the foramen ovale, which is located in the interatrial septum between the two atria, fails to close after birth. A ventricular septal defect is caused by incomplete development of the interventricular septum. So there's not a solid wall between the right and left ventricles. So oxygenated blood flows directly from the left ventricle into the right ventricle, where it mixes with deoxygenated blood. This condition is usually treated surgically. A patent ductus arteriosus is when there's a temporary blood vessel between the aorta and the pulmonary trunk in all fetal circulation. But usually right after birth, it closes. When you have a patent ductus arteriosus, patent means open. So the PDA, or the ductus arteriosus, remains open rather than closing. This results in aortic blood flow into the lower pressure pulmonary trunk and increases the pulmonary trunk blood pressure, overworking both ventricles. If the PDA is what we call uncomplicated, then medication can usually be used to facilitate or increase the closure of the defect. However, if it is a more severe case, then surgery is required to fix that PDA. Coarction of the aorta is a condition where the aorta has a segment that's too narrow, so there's not enough oxygenated blood flowing out to the body. So the left ventricle is being forced to pump harder and harder and harder, and high blood pressure develops. So coarction is usually repaired surgically by removing the area of obstruction. When all these conditions result, and there's the combination of 4 developmental defects, that is a condition that is referred to as teratology of Fallot. With teratology of Fallot, an interventricular septal defect is present. An aorta emerges from both ventricles instead of from the left ventricle only. There's a stenosed pulmonary valve and enlarged right ventricle. So this means there's a decreased flow of blood to the lungs and mixing of the blood from both sides of the heart. This causes cyanosis, or a blue coloration that's easily seen in nail beds and mucous membranes of a newborn when the level of deoxygenated hemoglobin is high. Remember, the blood color is more blue. In infants, this condition is referred to as blue baby. Despite the apparent complexity of this, surgical repair is usually successful and baby lives a long and happy life. So as we've seen as in other body systems that we've looked at, as we age, the body is less and less likely to be able to fully repair itself, and this can lead to a sclerosis or thickening of the valve flaps and lead to heart murmurs. The cardiovascular system, especially the sympathetic nervous stimulation of the cardiovascular system, is less able to respond to stressors and control cardiac output. Fibrosis of cardiac muscles results in a stiffening of cardiac cells as cells die and are replaced by fibrous connective tissue, so the heart muscle does not contract as fully coordinated as a unit. And then when we look at the blood vessels, we see atherosclerosis, or the changes in the great arteries where those lipid deposits that we talked about a while ago are being deposited, and also just arteriosclerosis, where the loss of elasticity doesn't allow the blood vessels to fully be able to withstand pressure and to vasodilate and vasoconstrict efficiently. Some terminology just to look at quickly. Asystole is a failure of the myocardium to contract. So I'm sure you've all watched the medical shows and you hear asystole when a patient is going into cardiac arrest, and that simply means that the myocardium is not contracting. Heart palpitations are when you have a strong, fast, or irregular heartbeat, most commonly caused by stress, drugs, or heart disorders. Hypertrophic cardiomyopathy. This is usually a congenital or a genetic disease that causes a thickening of the cardiac muscle cells, causes them to enlarge, the walls of the myocardium thicken, leading to very strong contractions, but the inability to completely relax, and so the ventricles fill with blood, and this has led to death in several athletes, especially during those summer training periods when the heart is working even harder and the body is trying to maintain homeostasis. All right, so quick question. Increase in stroke volume would cause, well, what do we know? Is stroke volume going to increase cardiac output? Possibly. Is it going to increase heart rate? Yeah, don't see how immediately, right? Increase in stroke volume, decrease venous return. Well, venous return is how much blood is coming back into the heart. So I'm thinking my guess is A. And surely we have an A as our answer. Nope, it's not going to show me the answer, but yes, the answer is definitely A, an increase in cardiac output, because cardiac output output is heart rate times stroke volume. The part of the conduction system that causes ventricular myocardial cells to contract, that would be your Purkinje fibers, because those are the small little fibers that go out and cause depolarization in the myocardium of the ventricles. And the last thing I wanted to show you was just a few irregular ECGs as compared to the normal ECG that you see here. Now, notice that your R to R interval, or the distance between consecutive R's, is very much the same between all of the consecutive R's. So this is considered a normal ECG. Now, again, I'm not going to test you on ECGs, but I do want you to be aware of how different conditions would affect what you see. I'm not going to ask you to look at an ECG and interpret it for me. You will need to know what P waves are, what QRS waves are, what T waves are. I'm going to also ask you to be able to tell me what you would see if a patient has tachycardia. How would their ECG appear? If a patient has bradycardia or fibrillation, how would their ECG appear? All right, so when we look at this first irregular ECG, this is a first-degree atrioventricular block. So remember, this is an arrhythmia that occurs when the electrical pathway between the atria and the ventricles is blocked. So it slows the transmission of nerve impulses. So look at this compared to this. Okay, so you see that all of the waves, the contractions, the depolarization is much more spread out. So you see a longer PQ interval. So the most common site of blockage that we talked about was there at the AV node. So this first degree AV block, the PQ interval is prolonged, and that usually causes, or is usually because conduction between the AV node or through the AV node is much slower than normal. So remember, the P wave is ventricular depolarization, and then we've got to depolarize, or I'm sorry, the P wave is atrial depolarization, and then the ventricles have to depolarize before the QRS. So look how long this section right here is compared to here, right? So that is a first degree heart block. All right, in atrial fibrillation, you see no detectable P waves. Okay, so the AFib is a common arrhythmia that affects mostly older adults, where contraction of the atrial fibers is asynchronous or not in unison. So the atria just stops pumping altogether. And that's what you see. No P waves detectable. And then we have two different things to look at on this particular strip of ECG paper. And the first one is ventricular tachycardia. And this is an arrhythmia. First of all, what does it mean? Ventricular, of the ventricles. Tachycardia, fast heart rate. Okay, so this is an arrhythmia that originates in the ventricles and is characterized by 4 or more premature ventricular contractions. It causes the ventricles to beat way too fast and at least 120 beats per minute. So look what you see. Ventricular tachycardia. It pretty much masks everything else because remember, the ventricles have the most cardiac muscle cells, so more depolarization. It's going to mask everything else. And on this end, we have ventricular fibrillation. Remember, fibrillation is the most deadly of all the arrhythmias because the contractions of the ventricular fibers are so asynchronous or out of unison that the ventricles quiver rather than contracting in a coordinated way. So the ventricles may eventually just stop pumping completely, and then coronary circulation fail, or circulatory failure and death is going to occur. So during ventricular fibrillation, the ECG doesn't have any defined P waves at all. The QRS complexes and the T waves are not well defined. Everything's just all jacked up because the ventricles, being that biggest change in electrical activity, is completely overshadowing and masking everything else. But even the ventricular waves are not anything that is synchronous, are not regular. So this, of course, is going to lead to death very quickly. All right, that finishes up the heart.